I'm Sheila Binney. I work with Rana, and I'm here to support her today because Sarah and Ivy and Kathy Lim aren't here.
Thank you for joining us. All right. So seems like we have everyone introduce themselves already. Thank you all for joining again. This is our agenda for today. We'll be going over the purpose of this session and review our guiding principles and the role of a subject matter expert. Then we'll jump right into doing a high-level overview of what the future state workflows will look like for community IB. So this includes when a patient is referred from Richmond Hospital to the Richmond Community IB program, when patients are referred from Richmond to an external community IB program, and lastly, when Richmond receives an external referral to their community IB program. We'll do a demo to show you what the existing community IB power plan looks like to make sure that it fits your needs. And then we'll have a short break and then continue on the demo to show you the provider end-to-end workflow, as well as the pharmacist workflow. And that will lead us to the end of our session. Okay, so in our last session, you gave us a lot of detailed information and helped us understand the current workflow related to community IB. The purpose of this session is to provide you the opportunity to understand how that workflow will be facilitated using CST Cerner in the future state. Again, we'll provide you a demo to show you how that workflow will be facilitated using the system and what tools you have available. And you can let us know if you identify any major gaps in what we present today, which will work to solution. This is a very brief overview of CST. The vision for the future is to have a connected health system that works for both patients and the people who care for them. We have 5 project drivers: patient safety first, best way every day, FaceTime, not chase time. We want to draw on data and strengthen our core. And a little bit about the CST system. It uses a model system from the States that is the base foundation for our design. It's a replica of a system that's already in use and based on global best practices. There have been many changes to the initial design from the number of go lives that we had. So the design today, we're starting from what we have right now post VGH and UBC go live, and changes will be made where necessary to Canadianize or meet requirements. Any changes that we make are in alignment with our 3 guiding principles. The first guiding principle is that we don't just change for the sake of change. There has to be a reason for the change, whether it's due to safety issues, if it's for regulatory reasons, financial reasons, or if there's missing content in the system. The second principle is that we focus our design to be enterprise. We try to design in a way so that we can standardize or meet the needs of all 3 health organizations. So that's PHSA, PHC, and BCH. And we prioritize design based on what's needed for go live. The third principle is our priority for must-haves. We need to go live with a functional system, so the must-haves must be completed prior to go live. Anything that we identify as a nice-to-have that is needed at some point in the future, that will be addressed later on after activation. For the subject matter experts that we have on the line today, you'll contribute as an expert and representative of your area as we rely on your help to review our recommendations for future state workflow. So you'll work collaboratively with us to finalize these contents and workflows. And you'll act as an agent of change and help communicate and advocate for the change process in your practice. So that's our introduction. Now let's get into doing a high-level overview of future state workflows. So the first workflow that we want to show you here is for internal referrals to the Richmond Community IB program. In this workflow, a provider at Richmond may place an ID consult for the patient. And then once the ID physician sees the patient, assesses them, and determines that they need to go for community IB, they would place the community IB power plan. This power plan contains all the orders needed, and it includes consults, pick insertions, your antibiotics, test dose, and lab tests. So the ID physician would fill out the power plan, including the different phases within it, but only initiate or activate certain phases and leave the other phases in a planned state so that it can be activated at a later time. And I'll show you these phases in the power plan when we do the demo. The ID physician will also have to request for a recurring encounter to be created for the patient through Message Center. Usually this would be done by unit clerks, but because there's no unit clerk for the Richmond Community IV team, the physician would have to request for one to be made. You can think of encounters as different books for the patient. So there might be an inpatient book, an outpatient book, and so on. This recurring encounter is used to keep the power plan that was placed active, because if it's placed on an inpatient encounter, let's say, and the patient gets discharged, the power plan will end up getting discontinued without the recurring encounter. And clinicians such as pharmacists won't be able to access the power plan later on to process the meds. We do need to create a new location in the system for the community IV program, because unlike other sites, your team isn't based out of a specific clinic. So we're not using any of the existing clinic locations for Richmond. Is there any disagreement on having the location named as RHS Community IV Program? Or if you prefer it to be called something else, please feel free to speak up as well.
It's fine.
Yeah, okay. So we've got that confirmed. Moving on to the next step. The TN's role in this workflow is to assess the referral for community IV and set up appointments for the patient. They would coordinate with the community IV pharmacist to arrange medication and supply pickup and perform discharge teaching as required. A lot of these steps are out of system and on Paris, so continue these steps as you normally do. For the community IV pharmacist, you would initiate or activate the subsequent phases of the power plan in that recurring encounter. And these would include the prescriptions and laboratory test phase. Then continue to ensure medications and supplies are ready for weekly pickup and delivery as you currently do. The patient is then discharged from Richmond, whether it's from inpatient, emerge, or outpatient. They would be given the prescriptions and lab recs by the community IV pharmacist, and a follow-up appointment will be scheduled for them to see the ID physician. At this point, we're not sure whether follow-up appointments will be done in OPAT or not in future states. That is something that is still being discussed, but if there will be appointments in OPAT, then we'll go through how the appointments will be scheduled in the next session. But for scheduling appointments in the doctor's office, you can continue your current workflow of, I believe, using Plexia, which is done by the ID physician's MOA. ID physician will see the patient, and when you've determined that the patient is okay to be discharged from the program, then they can initiate the end of treatment phase of the power plan, which will notify the pharmacist that therapy is complete. Something that's still outstanding as of now is who will be the one to discharge the encounter in the system. At other sites, it's usually the unit clerk who does this, but again, Richmond doesn't have a dedicated UC for the community IV program to do this. I'm wondering current state, is it normally the provider who determines that the patient is no longer part of the program, or is that responsibility shared with the pharmacist?
Sorry, I kind of missed a part of the question. What was the question again?
And whose responsibility is it to determine that the patient is discharged from the program?
From the home IV program?
That's right, yeah.
Us.
The providers, okay.
One question I'm not entirely clear. So if the patient is being discharged to long-term care, right now the process is the transitioners, I believe, book a follow-up appointment at the OPAT. towards the end of therapy. So how is that going to be working in Cerner?
Sorry, I guess to clarify, by discharge from the program, I mean to identify that they're no longer part of community IV anymore, that they no longer need antibiotics.
Yes, but my question is, there are some inpatients
Mhm.
who will be discharged from hospital to long-term care for home IV. And right now, this group of patients, they come back to OPAT, the IV clinic, for follow-up towards the end of therapy. So how is that workflow going to be different or the same in the Cerner system?
This one is specific to follow-up appointments.
Correct.
That piece we're still working out because we're not entirely sure whether once Richmond goes live with Cerner, whether there will be follow-up appointments or not in OPAT. So that one we're still having discussions with leadership on. That one we can address in our next session once we figure out more of whether the follow-up appointments will occur or not.
Yeah, because there are, and it's not just the long-term care, right? There's a subgroup of patients who have complex wounds going home on the home IV program. They're not being followed in our outpatient ID clinic. They're being followed at the OPAT. So it's not a small number of patients. So it will occur. Yeah.
I see. Can you clarify then when, for follow-up appointments, which patients go to the physician's office versus the OPAT clinic? Because what we heard last time was that if there's no space in the physician's office, then that would be when they go to OPAT.
That's not entirely true. So if they have, as I said, a complex wound, because we can't manage that in our outpatient office, or there's if they're long-term care, because they often have they can't really come to or schedule outpatient clinic appointment. So then the long-term care facility will have to arrange a transportation to arrive at OPAT to be reassessed.
Okay. Thank you for bringing that up. We'll make note of that and we'll make sure that it's part of the discussion regarding these follow-up appointments, because yeah, it does seem like a big group of patients impacted.
Yes. Yeah, because these ones sometimes have vac dressings and whatnot. They have to be managed with a nurse or a wound care nurse even sometimes for reassessments. Yeah.
Okay. Thank you for that. To be determined for next session. In terms of the discharge from the community IV program, is there something that you do to currently indicate that for the patient?
So usually what we do is currently what I do is I usually give the patient a prescription that says discontinue PICC line and discontinue home IV program, and then they just bring it to the home care nurse, and then they will take the PICC line out, and then they will be discharged from the program.
I see. So that's really it. There's no other discussion with the pharmacist or.
Well, usually Steve, correct me if I'm wrong. Once that it's in place, then I think if the pharmacy doesn't get any order for extension, then they just end on the date that it's previously ordered, so they don't get further antibiotics. That's my understanding. But Steve, please correct me if I'm wrong.
No, that's absolutely correct. If we are not notified, whatever the end date was, the original prescription is when we assume that the patient's no longer on the program. That's really why it's really important for pharmacy and probably community nurses to know when extensions occur.
Okay. So in that follow-up appointment, that's when Dr. Kwok, you would give the patient the prescription, or sorry, the order to end the prescriptions as well as to take out the PICC line. But after that follow-up appointment, does the patient usually have any further antibiotic doses still?
No, it will, after that, because they have no more IV access, right? So then they won't get any more IV antibiotics. Sometimes you may change them to oral antibiotic pills, but it would be through a prescription printed from Plexia.
I see. So before they come to see you for the follow-up appointment, they would usually have been done their course of antibiotics.
No, they usually would be sort of like a few days away from finishing.
Mhm.
Yeah.
And
So
then
we usually book the follow-up the week of their end date.
I see. Okay. And in your order, do you indicate the end date there, or has that been predetermined?
Which order are you talking about?
The one that you give the patient to take out the PICC line and.
Oh, so usually I just say discontinue the PICC line after last dose of antibiotics.
I see. Okay. All right, that is helpful information. We'll also take that back and we'll see where in determining the process of who will discharge the encounter. So we'll come back to you with that piece in the next session as well.
Okay.
Okay. The next workflow is for when the site is referring or sending a patient to an external community IV program. And specifically, this is for when the receiving site is on CST Cerner. Again, the physician at Richmond can place an ID consult for the patient where they can be seen by the ID physician. The ID physician can then assess the patient, and if they are to go for community IV, they would place the community IV power plan and initiate the appropriate phases. There is a separate order to be placed, and that is the community IV program new patient order. This order is used to trigger the UC at the receiving site to create an encounter for the patient. The Richmond TN will assess the referral, coordinate appointments with the receiving sites, and perform discharge teaching as required. In this case, from what we understand, the Richmond pharmacist isn't involved since the patient is in an external program. The patient will just be discharged, and the external site's ID physician and community IV team will assume care of that patient, and they can just refer to the patient's chart in the system to look at the orders.
So sorry. So I'm not understanding this scenario exactly. So this means that, let's say I have a patient in Richmond that I have seen, and then I send to, let's say, Lionsgate. Is that sort of okay? So right now the process is if we send to a different hospital.
Mm-hmm.
Whether it's Cerner or not Cerner, we basically the transition nurse sort of, come up with a form that we filled out, and then it involves a verbal communication between the ID physician here and then the receiving ID physician, and then they either can pick it up at OPAT or through the home IV program, depending on the antibiotic regimen. And then if it is a different health region, for example, Fraser Health, we actually get a lot of at Delta and Surrey. I don't know how it works in the CST Cerner, but right now there is a health screening form with a regional transfer that we have to fill out. And that's also facilitated by the transition nurse.
Yeah, the transition nurse, they can continue on to send the referral package as necessary. This one here is more specific to the orders where it'll be placed in the power plan, and then those that are the sites that are on Cerner can refer to the orders on the system, basically.
Okay, so basically I'm just placing the order, and then the transition nurse will sort of look after that. Is that what you're telling me?
That's right, yes. And then all the other pieces in the referral package, because I understand they also have some sort of care plan that they fill out and they send them to the appropriate teams, they would continue that as normal.
Okay.
All right. If the receiving site is not on CST Cerner, the workflow would be fairly similar. The difference is that the prescriptions and lab orders would have to be faxed along with the other materials that are faxed with the referral package to the ID physician and team at that site. Okay. Next slide is the workflow for a patient coming from an external site to the Richmond Community IV program. So this is as if a patient from St. Paul's was coming to Richmond. And if the sending site is on CST Cerner, their ID physician will be filling out the Community IV Power Plan, initiating the consult phase and other phases as needed on their end, and they'll leave the rest of the phases in a planned state. Now, it's part of existing workflow to place the Community IV program new patient order when sending a patient to another site, so that again, the UC at that receiving site can create the recurring encounter. But as we discussed before, there's no dedicated UC for Community IV at Richmond. So when this order is placed for the Richmond location, it doesn't really go anywhere. So we will determine the process of how the encounter will be created, whether it's through the provider making a request through Message Center, like in our initial workflow, or through a different process. So this piece will also be determined for our next session.
Well, so right now, any external site requiring home IV, they either call us or they fax a referral to my office, to Plexia. So basically, for example, if there is a patient at VGH on home IV and they want to, in VGH admitted and they want to send to Richmond home IV, then basically the VGH ID pharmacist will fax the referral to my office.
I see, and that includes the orders, right?
That includes the orders, but I don't know whether the ID pharmacist also fax something to our pharmacy. Maybe Steve, you can comment.
Yeah, so for example, Clement said that if it comes from VGH or St. Paul's, they will fax. They'll first of all call us to make sure that we're able to accept the patient, and then after we do, they will fax us the consult and the orders. Similar to when they fax it to the ID or Clement or Jerry. And then I'm assuming I think they also notify our Richmond Community Home Care nurses.
The out-of-system communication that you do will still occur. They will still fax the referral package. Though we will need to confirm whether the orders will be faxed or not, because if the two sites are on CST Cerner, then you do have access to the orders straight away into the system.
Correct.
Yeah. Yes, but any out-of-system communication that you currently do right now, please continue doing that as well. We're not taking that piece away from you. So yeah, we will determine how the encounter will be created in this workflow. Something that would be helpful for us to know, and I think you've already touched on this piece, it sounds like there is always communication beforehand, provider to provider, before you accept the patient. So you're always aware before you get the referral, is that correct?
Yes, but we don't actually know exactly sort of when they arrive or start, because they usually have an estimate saying, oh, maybe this patient will be discharged tomorrow or Friday or something like that. Then we'll be okay, we'll expect this patient, but sometimes things happen and they might not get discharged in a few days, or they might not ever even getting discharged because there's something else going on in the hospital. So we have an idea this patient may show up, but we don't know for sure like that patient will show up or not on the day that they expect.
I see. So before they come to your program, you basically have an idea of who the patient is, what kind of orders are there for them, just what is not 100% confirmed is exactly when they'll start.
Correct.
Okay. Okay, that's great to know. Thank you. Yeah, we will get back to you on this piece as well. So the patient will be discharged from the external site, and then the Richmond ID physician will assume care of the patient. And then in the system, you can review the power plan in that recurring encounter once it's made, just to make sure the orders look okay. All right. So this is if the sending site is on CST Cerner. Oh, whoops. Sorry, I think I might have missed some pieces here. Once the ID physician has reviewed the power plan, the Richmond Community IV pharmacist will initiate the subsequent phases of the plan, make sure that the medication and supplies are good to go for pickup and delivery, and they will be the ones giving the patient the prescription and lab recs. The patient will have a follow-up scheduled. Again, for appointments scheduled in the doctor's office, continue your current workflow of arranging those appointments, and we'll get you more information about these OPAT follow-up appointments in our next session. When the patient is to be discharged from the community IV program, the physician can initiate the end of treatment phase. And lastly, the encounter will need to be discharged, and that process is still to be determined. Any questions? If the sending site is not on CST Cerner, they won't have a power plan placed, so they'll just be faxing over the orders like current states. The Richmond ID physician will assume care of the patient, and what the physician has to do is request for the encounter creation through Message Center. Once that encounter has been made, the orders that were faxed can be entered as part of the community IV power plan, and the Richmond Community IV pharmacist can then initiate the prescription and lab test phases, and again, the same workflow of having meds and supplies ready for pickup and delivery. The patient will get their prescriptions and lab recs, will later have a follow-up with the ID physician, who can then initiate the end of treatment phase when the patient is ready to be discharged from the program. And then we have the same outstanding items for the follow-up appointments and discharging the encounter. Any questions about any of the workflows that we've just presented? I know we have a couple of outstanding items as well. So creating the encounter, discharging the encounter, and the follow-up appointments.
And there's another one that I don't know if I actually have gone through. So there are also patients who are at the OPAT being transferred to home IV. Mm-hmm. So how is that sort of captured in this system?
This will be this workflow. We'll count that as an internal referral since they are coming from Richmond to Richmond. So basically same thing if the patient was inpatient in Emerge or in OPAT, the ID physician, you would just be placing the community IV power plan. And within this power plan, it does trigger a consult to the transition nurse as well as pharmacist. So from there, the transition nurse can coordinate the appointments and send off the referral package.
Okay, thanks.
Yeah, no worries. Other than the outstanding items, were there any gaps that you've noticed in the workflow?
Sorry, there's no gap, but just for the last one where for referring sites on Cerner, that's step where the provider has to fill in the power plan. That is something different that from a current state, because in current state, the sending site would send their doctor's orders that we would process. Like Clement's group never had to write any other orders; they just followed them.
Mm-hmm.
So that's just a different step that the ID groups will need to know that they have to actually place the order.
Yes, yeah. Yeah, that is something that is different, because yeah, currently we understand that all you do is review the orders, but this one, you'll review it, but sort of transcribe it onto the system.
Well, then that's a little problematic because we don't know when they're actually discharged. Then how do I know when I'm supposed to enter that order?
You can, in the system, you can put it in a planned state. So what that does is, it's as if you've placed the order, but it's not yet active. So when the patient does come to Richmond, at that time, the pharmacist can then activate the orders. So before it's activated, it's just sitting in the chart.
So then it's our job, or isn't it not the referring site's job?
If the site is not on CST Cerner, then all they can do really is just fax you the orders. They aren't able to do anything in the system.
I see. So, but then if they are CST site, then they can.
Exactly, yes. So they'll be the ones placing the IV power plan over at their site, and then you can just review it in the system directly. You don't have to do any transcribing there.
So then how do I get these fax orders? Because I never get them.
Is it not in the referral package that you've mentioned, what you get from?
No, because these ones, they just sort of go to Steve, right? Like I never see them.
Yeah, I don't honestly know whether the providers, I know they get notified that a patient from outside Richmond is coming back to Richmond.
Mm-hmm.
But I don't know if they're given an actual order, or they'll just say, "Oh, patients on vancomycin for treatment."
Yeah, exactly. It's sort of a one-liner type of thing. Like I don't really, yeah. So I never get any faxes. Like if it is they sometimes fax us the referral to my office,
Mm-hmm.
but like it doesn't necessarily come in a timely manner. so I don't know, like yeah,
like there's always the opportunity that if the pharmacy has it, we could fax it to Clement. The thing with Clement, most of it, from my understanding, because the way Richmond's going live, it will probably only impact patients coming out of Vancouver Coastal, like from Fraser Health, because VGH, UVC, St. Paul's will all be on Cerner.
Yeah.
There'll be patients from like Delta, like going to
yeah. Delta is a big problem. Like what do I do? Well,
So
I mean that's
yeah, we just have to make sure that the providers get the prescription.
Because it's kind of, because we have two ID doctors, right? So the one that is in outpatient clinic is different than the one who's on call. So then how does that work?
Mm-hmm. I guess it was our understanding that the providers currently do get the orders, since we were told that the providers review the orders, but it seems like it's just, I guess, maybe a summary and not the full orders themselves.
Correct. Yeah.
Steve, were you mentioning that there is a way for the pharmacist to communicate the orders to the physicians?
We could fax it over to the providers, but we just need to know which provider to fax it to.
Mm-hmm.
So that's the only problem. It's Clement, Luke, and Jerry. So I don't know if there was a centralized location we could fax to, we would. But I guess we'd have to say, oh, who's on service today, and fax to them. But like Clement says, he doesn't know that that patient's being discharged. We'll say, oh, it's being discharged on Friday or Monday. And so they'd have to put in the order on a planned state so that in case it gets deferred like Wednesday, we would still have it active.
Yeah, so then that might be the new workflow then. So if there's anything outside of sort of Cerner, then maybe somebody from pharmacy somehow have to let one of us know this is coming.
I think that's possible, absolutely.
Yeah.
I can't see the referring site unless we tell them to fax the actual orders to the ID providers as well. And it probably won't get done properly.
Yeah. So yeah. Okay. So that may be the new workflow then. Okay.
Yep. Yeah. So now maybe we can identify that on that particular one to say that, you know, pharmacy will fax orders to ID providers to complete the power plan.
Yeah, we'll make note of that. So when you accept a patient, are you accepting a patient under the 3 ID physicians, or is each ID physician sort of assigned to a particular patient?
So usually I think, you know, whoever took the phone call, I guess, kind of is sort of under that person, but we sort of share, you know, because every week is a different person, right? So, and if it's, you know, whoever that week's person sort of take all the calls.
Okay.
Yeah.
Yeah, it sounds like if pharmacists could send it to a centralized location, that would help.
So the other thing that you run into, I don't know if we've talked about, but it probably hopefully won't be a huge issue, because when we do, it's from a Cerner site like St. Paul's, is where the sending provider will actually follow their patients and adjust their doses. But our physicians here are just basically overseeing the program. So they know that Mr. Smith is on the program, but a provider at St. Paul's, at the CF clinic or whatever, will be actually following the patient. And they will be adjusting doses and antibiotics as needed. And the ID providers on our side just knows that there's a patient on here on this drug and so on.
Yeah, that's a good point. That actually does show up periodically. Yeah. So how is that going to work?
Yeah, because in those cases, Steve, do any of the pharmacists at Richmond modify any of the prescriptions in case it's required, or do you just communicate back to the sending provider?
So it depends on the drug, but normally if it's something that we need to monitor, like vancomycin, we would communicate with the sending physician, because we know that they'll want to follow the IV home IV pharmacist at St. Paul's would let us know that, we'll follow all this. Any changes, we'll let you know. But that's St. Paul's. I don't know how often that happens when they come from Fraser Health. I don't think it does, but it's usually St. Paul's that we run into a situation like this from.
I see. Okay. We'll take that piece back. I'm not sure if it's going to be where the pharmacists, you continue on to communicate with the sending provider, and if they do make any changes, not sure if the workflow will just be for pharmacists to modify on the power plan again. We will confirm that. Lots of different scenarios that occur.
Absolutely.
Okay. Any other points or questions that you want to bring up before we do the demo?
Sorry, just one more scenario, and I can't remember whether you covered it, is when a provider in the community will start a patient on home IV because they were, for example, they were previously on it, they stopped, and then they want to continue. It's happened a couple of times, especially with the respirologist. I would assume that because they are from Richmond, that they would or would not have access to Cerner and would put it through there. I would think that, I guess that'd be an external referral then.
Our understanding from last session is that it still needs to go through the Richmond ID physician.
Okay.
Yeah.
Thank
you. All right, if there aren't any other questions, we have the demo next. So before Jessica and Nicole present the provider and pharmacist workflow, I do just want to provide an overview of what the power plan looks like in the system and just make sure that it fits your needs. And Jessica and Nicole will also go through the power plan again as part of the provider and pharmacist demo. So it will be more specific then to the relevant position. Okay. So I'm going to go search for the community IV power plan here. And this is a multi-phase power plan because of the many phases within it, and we'll go into each one. When you search for the community IV power plan, a window will pop up. And this is where you can see the initial start date, which you can enter and adjust as necessary. We have consults, which we will initiate right now so that it's active right away. For the PIC insertion, you can plan this for a later date, depending on when you'd like it to be inserted, or if the patient already has a PIC, then of course you don't need to order it. We have a test dose phase, and this is in case there's a change of drugs and the patient requires a test dose. Prescriptions and labs, these are ordered for a future visit and would be activated by the pharmacist. We also have PO prescriptions available too, if you happen to want to order any. And end of treatment will be initiated by the provider to notify staff that this patient is now discharged from community IV. Click OK, and then the provider can enter or select the relevant orders in each phase. There's lots of different options that you can choose from, and it can certainly look a bit intimidating, but the more you use it, the easier it will get. So for the consults phase, you already have the community IV consult, community IV pharmacist consult, and TST consult pre-selected. If there are any others that you'd like to select, go ahead. And we have orders for PIC insertion here if needed. The next phase is test dose. There are two options listed here. So we have daptomycin and ertapenem, but if there's something you're looking for that isn't here, you would just add to phase, and this would be how you would add the order into the power plan. So a window will pop up where you can just search up the medication to add into the power plan here. In our prescriptions phase, these are all your options. Again, if what you're looking for isn't here, you can add to phase to add that order into the power plan. Down at the option, we have the alt place order pre-selected for block PIC lines. And again, we have a phase for PO prescriptions if you are needing to order any PO medications. Then for laboratory test, these are the three that have been pre-selected, as these are what's commonly ordered. You can select any others that you'd like, or if it's not here, you can use the add to phase function. The prescription phase and the laboratory test phase will be initiated by the pharmacist, so the prescriptions can be printed with the lab recs and the patient can be given a copy. End of treatment phase. Whenever the ID physician decides that everything is going well and the patient can be discharged from the program, then they can initiate this phase, which will alert the pharmacist that therapy is complete. So this is the power plan. Are there any orders that you place often that aren't in this power plan? I know that I did go through it pretty quickly here. We also did send screenshots from our last session.
What I'm worried about.
Sorry, right now when we fill out the home IV orders, have a occluded PIC line pre-printed order set. Is that sort of incorporated here? That's this
So
one.
we'll have yes, we'll have these PIC orders instead, which you'll select from.
No, but this is not about the insertion of the PIC. It's after the PIC is inserted.
I see. Oh, sorry, remove PIC orders. We have this if/when IV community antibiotic therapy completed, the nurse to remove PIC line.
I think it's more around the altarplace. Getting so at the bottom they have the altarplace for plug occluded lines. Is that what you're referring to, Clement?
Yes. So it's somewhere here.
Yes, we have the altarplace order here.
Oh, okay.
And it's already pre-selected, so you don't need to make sure you select it in case you forgot.
And is there an order for PIC care to the community nurse?
PIC care.
Like PIC line care.
I didn't notice a specific PIC line care. Let me check in the, let's see in this one here.
Because they do the dressing changes and all that based on that order.
Mm-hmm.
Yeah, so Dr. Kwok, community nurses don't use Cerner, so they would just kind of follow their current process in terms of like receiving orders or if there's any specific instructions.
Well, right now I'm writing PIC care on the community form. Then how do I do that in Cerner?
So the community form, is that part of the package to the transition nurse?
Yes.
Yeah, so they would just kind of follow that the same way, because I believe, Tiffany, maybe you can correct me if I'm wrong, that package still continues?
Oh, so then I do a separate paper form then? I don't understand.
Sorry, the referral package themselves continue, but orders are usually faxed by the TN to the home IV team. So you could enter an order here for community IV nurse to do their home care, which gets printed off and sent to them.
Oh, so it would be a free text order then? Is that what it is then?
It looks like. Not a free text, but you do have the option to add a PIC care or line care order.
Oh, I see. Okay. And then once I enter, then the transition nurse will print and fax to the community nurse.
Yes, they can print and fax all these orders that you've entered in the power plan and send it off as part of their referral package.
Can you not just make it part of the power plan?
This power plan has been designed already with multiple sites involved. So if there are any orders that you'd like requested to be in here, we will have to reach out to our orders to review that request. And
so how does VGH enter that? They just do the free text then?
I'm not 100% sure, but we can get back to you on that.
Yeah, I'm curious
sure.
Because it's pretty standard.
Yeah, Claire, sorry to put you on the spot. I'm not sure if you happen to know what they currently do for line care.
No, sorry, but I'll try to reach out to Dr. Wright. I believe she's on vacation for another week, so.
Okay.
Dr. Kwok, just one quick question. Has the order set reached out to you to do any kind of order set build, gap analysis and things like that?
Not for IV.
Not for ID.
No,
Not yet.
not yet.
Okay. So maybe Tiffany, we can capture that and then we can reach out to the order set team as well, because I know the order set team are doing gap analysis and requirement gathering for all the Richmond order sets as well. So we can kind of put forward this as one of the requests from the ID team. And then they can follow the process of like seeing if there's a gap, and sounds like this is a gap.
Yeah, and on that note, there are many patients also have a wound at the same time. So the current process is on the community form. We also put down wound care of wherever. So that again is is problematic if it's not sort of captured somehow.
And the wound care is also for the community nurses, correct?
Yeah, exactly. Yeah.
Okay. So yeah, so maybe we'll capture that and then we'll pass the request over to our order set team. And then if they need to kind of do any kind of changes, they will reach out to you, because I know that they are in the process of reaching out to all the different specialties to gather any kind of gaps and requirements as well. So we'll definitely pass forward, and then we'll follow up with them.
Okay.
Good, Hilda.
Thank you.
Yeah, we did try reaching out to order sets and if they were going to do or have a session, but because this power plan is an existing power plan already that multiple sites are using, they said they weren't going to do that. But if there are any gaps, which we've noted now, to reach out to them. So I'm sure there will be follow-up communication with this afterwards. Any other orders that you'd like to point out?
No.
No, okay. And Steve, do the medications look all right on your end?
Yeah, yep, they look reasonable.
Okay. Great. All right, so we'll bring that back to our order sets team. And are there any questions regarding this power plan?
Not for me.
But sorry, just one quick question. I noticed a lot of these, they're all CAD or yeah, CAD bags. Are there any gravity bags indicated here?
Let me see. Sorry, I'm not too familiar with the CAD bags, gravity bags, but are these medications not used for gravity?
They are, but they also CAD, for example, ceftriaxone 2 grams. That could be just a gravity bag, or it could be a CAD bag. So I'm just curious how we would differentiate, or we just communicate with the transition nurse about that.
I believe it would just be communication with the transition nurse.
No, that's fine. Yeah, because usually the providers don't indicate that because they don't need to know that. It's the nurse and pharmacy. But okay, that's fine. Thank you.
All right. If there aren't any more questions, we'll give everyone a 10-minute break and we'll resume the demo for provider workflow and pharmacist workflow afterwards. So you can come back at 11:10. It's 11:10. I hope everyone is back. We'll go ahead and resume our demo. So I'll pass it off to Jessica to go over the provider end-to-end workflow.
Thanks, Tiffany. Just one moment. Sorry, my domain is just loading up again. It decided to take a break as well. So sorry, just one moment and I'll get it right back up. And while this is loading, Dr. Kwok, again, my name is Jessica Ballou. I'm with the provider adoption team. I will be leading you and your team of infectious diseases providers through what we call workflow reviews at a later point prior to go live. So we will be meeting again in person later on. But today I wanted to take you through a demo while this is loading of just kind of what your workflow would look like in system, starting with finding the patient, reviewing some orders, and I also wanted to speak a little bit about the documentation piece. And it is loading, so it should just take another few seconds and I'll get that up for us. Apologies for the delay.
No worries, it happens a lot.
Okay, let's see. All right, and I'm just going to share my screen. Okay, here we are. Sorry again about that. Let me just hide a few things. Okay, Dr. Kwok, can you just confirm, and team, can you confirm that you can see my screen?
Yes.
Excellent. Okay, so I have logged in today as our infectious disease provider. My landing page is Message Center. I don't have much to see there today, but it's kind of like your one-stop shop for looking at things like results that may have been sent back to you for review, documents if you're working with residents, for example, any messages that are sent through the Cerner system will also display here. Today, I am going to bring us over to a couple tools in the toolbar where we can look at patient lists, and I'll make this part pretty brief. Depending on where you're seeing this patient, you can find them in different lists in the system. For example, if you are consulting on a patient on an inpatient unit, you can utilize what we call patient list, which is also patient overview, but this overview just gives you more of a contextual view of some of the clinical information. And so right now I'm in patient overview in the toolbar. I have created a list so that patients I've established a consulting provider relationship automatically appear for me. And I can see a little bit of their clinical information here, like why they're in the hospital, some of their chronic problems, and things like isolation. And Dr. Kwok, you'll have the ability to configure some of this as well and pull certain things on the screen per your preference. So this is one way that we can organize our patients on the inpatient side. If you're seeing a patient in OPAT, for example, that's when you might use more of a tool like Ambulatory Organizer, where you can pull in patients that are scheduled for a resource. And as an example, I've got our VGH OPAT resource group here. So any patients that were scheduled for these providers would appear here for this day in the day view. You can see that we also have a resource for OPAT MD too. So you've got a couple different tools here for managing your list in the system, and my team will be helping you set up those lists on your profile so that when we do go live late or middle next year, you'll have all that set up for you. I'm just going to come back to patient overview for a moment. And in this demo, I'm going to use a patient who is actually registered on the inpatient side, but over at VGH, because I do want to show you some of the orders that we have in the plan, which aren't available right now at Richmond, on my view anyway. Today, I'm going to select the patient's name in blue. If I hadn't already established a relationship with this patient, that would be the first prompt that I receive, where I would indicate that I'm the consulting provider. Once I'm in the patient's chart, just a few things to point out here: that you've got your toolbar up at the top. You can always come back to those list or message center as needed. Below that is where you'll see your patient's name in the banner bar in the upper left corner. And here you do get some demographic and clinical information such as allergies, a code status, for example, if the patient's in isolation. You can even see that in the banner bar too. And on the far right side is where you'll see the patient's location for that encounter that you're currently in, which is important as well. So just, you can have up to 2 charts open at a time. We just want to make sure that you know that you're in the right patient's chart and the right encounter. So that's one way you can see that in the banner bar. On the left side of the screen is where you have your table of contents menu, which allows you to navigate throughout the chart. As a default for your position, you will have provider view as your landing page. So I'm just going to minimize this for a moment and show you here that for your role as an ID provider, you'll have different workflow tabs that correspond with different workflows to support your inpatient and outpatient work at Richmond. For today, since this patient is on an inpatient unit, I could, for example, review the rounding workflow page. These workflow pages have different components that you can move around and resequence. You can remove things that aren't relevant to you. You can do things like reviewing what other providers may have placed in the hospital course section for the chart, if it's an inpatient. You can review previous documentation, for example. Here I can see that maybe we're preparing for discharge for this patient. So the general internal medicine provider created a discharge note, and you could come in and review those notes there too. We'll teach you later on about some other tools within this document viewer, things like tagging, where you can actually pull information from other notes into your note as well. You also have filters too. So if you just wanted to see what other ID providers were writing in this patient's chart, that's when you can come over and apply some different filters there. You can do things such as reviewing the patient's history, and notice that there's a couple different tabs there, such as medical, surgical history, family and social history there too. And again, keep in mind that a lot of this data, once it's put in the patient's record, it follows the patients throughout their CST Cerner journey from inpatient to outpatient when they're readmitted, for example. And you'll find too that a lot of this information can automatically pull into your notes as well. Then we have some results tabs, and I don't have much in here today, I apologize, but you can view diagnostic reports as well as images. You also have the ability to review labs. External labs will display in CST Cerner if the ordering provider for that lab is a CST Cerner provider. So in other words, as long as it has a route of sending that information back into the system, that you may see those results in labs component. They display with the letters EXT there. However, you'll always have this access in the links component to Care Connect. So in the event that you are looking for those community results that may be ordered by someone else not associated with CST Cerner, you'll still have that access here through Care Connect, and it'll pull up the patient in a contextual view and actually keep you in the record. So it is a more efficient way of accessing Care Connect than going to the website. Just a few more things, excuse me, I should have known better than clicking there. You can also view the orders profile from here. There's a couple ways you can do it in the chart, but here you can see some of those orders. You can see, for example, medications. I can see that the patient's currently on azithromycin here. And I just want to point out quickly, because I know this is important for you all, that you do have the ability to also view orders in the blue menu, and sometimes that's easier. So if you're just wanting to see if, for example, antibiotics were ordered, sometimes coming to this view and looking at different power plans can be helpful, or looking at specific order types. And Dr. Kwok, for you, the MAR summary will also be helpful if you're looking for things such as antibiotics. There's some different views within this medication administration record where you can come in and actually look at certain types of medications. You've got some filters you can apply, and again, we can help you set those up too. So just some different tools here that you have within the system and when we're viewing information. You can also see, for example, active issues. If, for example, that internal medicine provider has diagnosed the patient with pneumonia, for example, then you would see that here. And finally, in the workflow pages, when you scroll down toward the bottom is typically where you'll find narrative components, where if you are consulting on a patient and you plan to create a note, then using these components just helps you build up your chart as you're reviewing information. And again, we'll show you that later on. For today, I'm just going to put in, just something basic so we can see how this flows in. This part is optional. You don't have to start to create your note on these workflow pages, but there are some tools where you can actually pull up a document, and insert your notes on this scratch pad type of component so that it's easier for you to transcribe some of that data instead of having to remember it or jot it down on a sticky note. You can add that info there and it'll flow into your note later on. And finally, at the bottom of the workflow pages, I would like to point out that you have different note types. So these note types will depend on the workflow page that you're in. So right now I can say I'm in rounding. I've got a progress note as well as consult notes. And you'll see here that we have free text options too. If I were over in the outpatient chart, for example, just to show you quickly, there are clinic note templates here and virtual visit note templates. So if you are seeing a patient in OPAT, for example, that's when you can leverage some of these notes. An important reminder for documentation is that progress notes in our system do not distribute. So if you are intending for this note to make it to Care Connect and to go back to that primary care provider or the referring provider, that's when you could utilize a consult or a clinic note. So progress notes don't distribute. That's just an important piece of information for your awareness. Okay, so now that I've done a chart review, I'm going to hop over to orders. I can see here again that there are some admission orders. If I wanted, I could peruse through those. I could look at other medications in the orders profile. Once that patient has been deemed appropriate for your community IV program, we're going to place some orders. And to do that, I'm actually going to just hop back over to inpatient quick orders. We haven't talked about this yet, but there are also quick orders workflow pages where for the ID position, we've worked very closely with our champions like Dr. Queenie Din, Dr. Richard Lester. We've worked to develop these pages so that it provides you and your team with common orders that you can easily pick and process. Just keep in mind, you'll always be able to search for orders as well. And the benefit of quick orders is you can pull favorites here, which is what I've done here for the community IV program plan. Now, the first thing I want to talk about before we get into the plan, which Tiffany's done a great job of reviewing, is that order for the community IV program new patient. And Tiffany mentioned earlier that this order sends a notification to the unit clerk at the receiving site to create an encounter for a patient. And so I just want to show you how I can use new order entry. I can go to my orders for signature, and I just want to open up this order and show you what this looks like. So here's where you would indicate your scheduling priority, next available appointment, for example, the visit modality. If it's not selected, it will default to in-person, but there are some other options there for you. The location today in this demo, I'll select the ID clinic because this is where that patient will be seen over at VGH. And I'm going to put something here and the reason for referral. Any other special instructions for the clerk to see can also be noted here in this order. And if there is a specific provider that you're requesting for this patient, that's when you can add that information to requested provider. Otherwise, it will default to blank and the patient will be booked per your instructions here. Now, keep in mind too, you always have the ability to favorite orders in the system too. So if this is an order that you see yourself placing again in the future, you could always add it to your favorites list. Next, I'm going to select sign. And that's the community IV program order. And so again, I have favorited this order and I can see it over on the right side of my screen. In the future, if I'm sending a patient to the VGH ID clinic for IV antibiotics, next available appointment, I can just select order and come up and sign the order and make it pretty quick process for you. Okay, next I'm going to come over to the left side of inpatient quick orders and show you here the ID community IV program power plan. Since Tiffany did thoroughly review this, I'm just going to open up the plan. You'll see again the add plan details, the date and time appear up at the top. So I'm not going to touch that for now because I do want those consults to be initiated at this time once I've signed the orders. I'm also going to just quickly note that the consults order is defaulted to become active once I sign the orders, but the other phases of this plan do not become active. They will be planned for a later date, and they will be initiated by the pharmacist, for example, or later on by the provider if you're ending treatment. I'm just going to select OK. So as you can see, I didn't have to change anything on that window. It looks like a lot of information, but it's already configured to have the phases default to certain statuses to support your workflow. When you open up the order or the plan, excuse me, all of the orders appear on the right side of the screen. All the phases display. It's a nice cumulative view of everything. But my recommendation for you as you're getting used to using this plan is to look over on the left, find that plan that's selected in blue. And I encourage you to go into the plan separately. It just makes it more of a cleaner view. And again, once you get more familiar with using the system, you may like that cumulative view where you can go through and pick things quickly. But I'm just going to open up consults. I can see here that 2 orders are already selected, and I do want to quickly show you this TST consult where we can indicate the estimated date of discharge. So if we're anticipating this will be within a week, and we want to add any special instructions, here we can do that in this TST consult order. Otherwise, if I need to select any other orders, I can. Just going to come back to the left, and Tiffany already looked at the pick insertion orders. And again, that alt to place, excuse me, the alt to place was not there, it was somewhere else, but the pick insertion orders would display, medications, labs, consults, patient care orders, those types of things. The test dose, if a test dose is warranted, you can see here that there are some colors that appear within the different phases. For example, the provider, pharmacist, or nurse will be initiating that test dose phase. And any other clinical decision support text can be found in yellow when you're looking at the power plants in our system. Just hopping down to IV prescriptions. So our consult for pharmacy is already selected for us, but I still need to pick the IV antibiotic order. And I'm going to scroll down. I can see that there are some green guiding text. If I'm looking for a specific frequency of vancomycin, for example, in today's demo, I'll just pick the Q12. On the right side of the screen, I can see that 750 milligrams, Q12 IV. I can also use the drop down here to pick different doses if appropriate. And keep in mind too, Dr. Kwok, you'll always have the ability, once you've selected an order, to come in and modify the details. And for example, like I can see the stop dates blank here. You could come in and you could indicate, whatever, if that's appropriate. Maybe you don't know yet at this time, but you can come in and modify those, or those can be modified at a later point as well. And then laboratory tests, I already have a few labs selected for me, CBC, sodium, potassium, urea, creatinine, but I can also come down and select other level, vancomycin trough level, for example. I can select that since I'm prescribing vanc at a later point. Next, I'm just going to come back up to my parent plan again, this ID Community IV program. And again, this is your cumulative view of everything. As you review the orders, again, continuing to making modifications if needed. If that looks all right, I'm going to then select orders for signature. And this is where I can get a better view of the orders I selected. So I picked that TST consult, the community IV pharmacist consult. We have an order for notification for them. The Alta place was already selected with the PRN indicating for the duration of antibiotic therapy. It's there if needed. The vancomycin, which I still have something that's required there. Oh, that's the stop date. Okay, so I'm just going to come in and place that there. And then my other labs down below. Next, I'm going to select sign. And I'm going to come over to orders, refresh my screen. Looks like it already did for me. And I like to point out here that you can see the different phases and the status. So if there's any question, if an order got initiated, or if it's there, it's available for someone else to initiate, this is where you can come and see that information. So I can see consults were ordered. I can see those IV prescriptions are future and will be initiated later on. Keep in mind too, Dr. Kwok, you'll have the ability to come in and let's say that, a PO prescription is not warranted initially, but it is later on. That's when you can come in and still utilize these power plans and make adjustments to orders within the plan. Any questions about that before I move on to documentation? Okay, hearing none. If anything comes up, just let me know. I'll go back to it. I'm just going to hop back over to my provider view, which I can also select home and come back to this viewpoint. For today, I'm going to select rounding, come back here, and I want to open up an example of a consult note. And again, you'll see that there's two different options for you. There is the structured ID consult note, which I'll select first, just to show you that this type of note has different sections that you can input data into. If they're left blank, they fall off the note automatically. Some of the sections already have information that populate from the patient's chart. At this point, you could utilize your microphone and dictate directly into the sections. You also have a tool called auto text in our system, which is where we can build out templates where you can use a strike on your keyboard. Template, wow. For example, I'm going to pull one up for medicine, which is a physical exam, and you can see that it pre-populates text in here. In a moment, I will actually show you some that we've built for VGH for ID. But I just like to show you that here, this is a structured template. It was validated on our enterprise level. You can't really make changes to this section headers in this view, but keep in mind that there's quite a bit here that it has to offer. And if something's not applicable for this note, you can simply leave it blank and it'll fall off, or you have some ability to remove sections from the notes if appropriate. Also keep in mind your assessment and plan can be modified in this view. You can also actually add active issues as the ID provider if they're appropriate, which would flow into this note as well. I'm going to select sign and submit and take you here to the sign submit window. You can see that the consult note is already there for my type. There's already a title. You can add information to this if appropriate. Because it's at a consult note, it will automatically distribute to Care Connect as well as the primary care provider and the referring provider. You'll have the ability to add additional providers in here as well if other providers need to see a copy of this note. And once finished, we'll select sign and the note will distribute. So that's the structured template type of note. Now, if I were to come back here and look at the free text note, just as it sounds, it is a blank slate. There's nothing here. At this point, you could use your microphone and dictate your wording into this note. But I want to show you an example of some auto text templates. In CST Cerner, we have built public auto text templates, meaning you'll be able to find templates through using our comma command, ID underscore. These are all publicly available. So we've got some already built out for St. Paul's as well as VGH. We also want to support our Richmond ID providers, so we will be seeking your input on a few of these as well. And if you have any thoughts about new templates, for example, we will welcome that as well. And I'll be working with your team for that. But in this example, you can see here that we have an ID VGH progress note for community IV, which I do plan to show you. We also have this VGH treatment summary for inpatient. So if this is truly an inpatient consult, maybe I want to use more of the inpatient treatment summary, and I can come in and I can indicate details here. There's some drop-down lists. You can use your microphone to dictate into these different sections. And Dr. Kwok, just because this is available on a public level doesn't mean that you have to use this. You can duplicate it, make customizations. If you and your team have a standard way of capturing consults for community IV or consults for ID in general, then we'd be happy to review these with you and also build new ones if that's appropriate. Now, I do want to show you that I also have the progress clinic note for community IV. And you can see here that they've also got some things pre-populated. Visit type, for example, if it was in-person telehealth, the community IV location. I think maybe we would need to update this perhaps. But I'm interested in your thoughts and if you think something like this would be would support your workflow and Dr. Vortel's and Dr. McLaughlin's documentation.
So this is just for home IV, or is it for OPAT as well? Because for home IV patients, we use Plexia, so we don't really use Cerner for our office. So then this will, I presume, applicable only to the OPAT follow-up patients for the home IV.
Yeah, that's a good point. And yes, we do have, it looks like VGH did create some OPAT type of templates as well, which we could explore using those for OPAT for Richmond. But correct, for your ID clinic, that will be outside of CST Cerner right now. So that would be Plexia. For inpatients at Richmond, where you've been consulted to see the patients, that's when you would use your documentation in CST Cerner. And then for those patients in OPAT. Now, for home IV patients, though, Dr. Kwok, I think maybe this is where you can help me clarify. Are you seeing them initially in the OPAT space? Or
so the home IV patients, they can come from anywhere. They can be initially an inpatient, they can be initially an OPAT patient, or they can be initially sort of an outpatient.
mm-hmm.
And they can, once they are discharged as an inpatient, then they would either be followed in our own private clinic or at the OPAT.
Okay, I see. And if it's private clinic, then your documentation would be outside of Cerner, whereas
Correct.
OPAT would be in the system. Yeah.
Correct.
Yeah. Okay, well, yeah, so I think for us as a takeaway, I know I've gone a little long on my time here, but I would be happy to send you some of these templates, you and the team, just to get you all looking at these and reviewing them and seeing if they would possibly work for you, if you'd want to make changes to those. And then I can take them back to our build team to build them in the system. Is that all right if I communicate these to you through email, show you some examples? Yeah,
sounds great.
Okay. I'll do that. Yeah. Okay, then I am just going to cancel here. So the last piece that I wanted to show you, and Tiffany mentioned this in the workflow earlier as well, is requesting an encounter when we need a recurring encounter for a patient for home IV or for community IV. And I want to just introduce you to the tools. So right now I'm in this patient's chart. I'm going to come back up to the toolbar. I'm going to select communicate. And by doing so, it automatically pulls in my patient's information. I've got some things I can complete up at the top, like the to line, who am I sending this to? You'll have the ability to create a personal address book, which is what I've done kind of in the middle of the screen. I'm going to just use VGH encounter creation as an example, but in the future, there will be a Richmond encounter creation inbox as well. There are different subjects that can be selected, and here we have one for encounter creation request. And essentially what that does is it pre-populates information down below that you can fill out to request that information. One of the key takeaways is for the encounter type, the patient needs a recurring encounter. And so that's, we would fill out some of the additional information, but the encounter type would be recurring. So I just want to show you one example of something I did today or previously. I selected that encounter creation request from the dropdown, but I built out an auto text and I basically took that same encounter creation request, but I plugged in some smart templates that automatically pull information for me. So we can make this process easier for you. We can automatically pull in the name, the date of birth, the medical record number. You can pre-populate that with encounter type recurring, location, RHS, IV clinic, something like that. This is just an example, but I wanted to show you that process of opening up this message within the patient's chart. Already has the patient populated. We choose someone quickly from our address book and populate that information below. And again, that's the thinking behind that is, you're aware that the patient would need those encounters if they're not in the system. Sending that message to the encounter creation pool can then get that recurring encounter placed or created in the system. And Tiffany, just going to ask if you have any other thoughts or things that you wanted to say about that process.
No, I think that was great detail you provided, Jessica. Thanks.
Thank you. All right, sorry, I know I went a little bit over my time, but I'm just going to stop sharing. Dr. Kwok, do you have any other questions for us at this time?
No.
Okay, thank you. We'll be in touch soon.
All right, thanks, Jessica. And now I believe Kinson will be providing the pharmacist workflow demo.
I'll just be sharing my screen. Share. All right, can everyone see my screen?
Yes.
Oh, thank you. So hi everyone, I'm Kingston. I'm one of the pharmacists with the Med Management Design team. Today I'll be demoing how to view the community IV pharmacist consults from the multi-patient task list, and also demo how to initiate the IV prescriptions phase and laboratory test phases in the community IV power plan. And I'll also show how to make modifications to the IV prescriptions phase as well. So we'll start off with the multi-patient task list first, and this is how you'll view the consults to the community IV pharmacist. Our test demo patient was this Build CST Med community IV demo patient, and we could see that the consult was fired to this list when the provider initially placed the consult within the power plan. And for the community IV pharmacist, they would just have to set this view to Richmond community home IV patients. Now we'll go back to the IV prescription phase of the power plan. So we'll start as though the provider has already placed the IV prescription phase and lab test phases in the future status here. When the provider initially places the community IV power plan, it actually fires a notification to the pharmacy patient management queue, the PPM queue.
Sorry to interrupt.
Oh yeah.
We're just still stuck on the NPTL screen right now.
Oh, let's see. Let me. Oh, I'm sorry, that closed my power chart. I'll just go back in.
No worries.
So I'll just pull up power chart in one moment. Okay, can everyone see my screen now?
Yes, we see the orders page now.
Oh, perfect. So I'll go back to the IV prescriptions phase of the power plan here. So we'll just start off as though the provider has already placed the IV prescriptions and lab phases in a future status. So when they do that initially, that fires off a notification to the pharmacy patient manager queue, the PPM queue, and this is visible on the pharmacist side. And let me just make the view a bit cleaner here. And from the pharmacy side, they'll see this pharmacy community IV notification, and this is set to a future status. This means that the IV prescription phase hasn't been initiated yet, but it's just put into future status. So this is just an indicator to the dispensary that the patient is in the home IV program. Going back to the prescription phase. As you can see here, the IV prescription phase contains the antibiotic to be prescribed. In this case, I just selected ampicillin. There's also alteplase for the lumen occlusion, and this will, so after activation of this phase, this will update the notification in the PPM queue and move it from a future status to an ordered status as well. And if modifications to the IV prescription phase is needed, and for instance, and if the pharmacist has not initiated the phase yet, you can go into the drug entry here by clicking it, hitting right-clicking, modify without resending. And let's say, for instance, you needed to change the stop date of the prescription to October the 10th, and you would just go into the field here and update the date. Leave the dispense quantity of the bags to 1 bag. The dispensary will dictate how many bags will be dispensed, and hit orders for signature to save the modification, and then hit sign. Make sure to hit refresh as well to get the most recent view. And as you can see here, the change, there's a small modification here to the stop date to October the 10th, which is what we wanted.
Yeah, Kenson, sorry, Steve here. Just quick question. What are the 3 Vankos indication at the bottom there mean?
Oh, these are, this just comes from the power plan itself. Even if you don't select vancomycin even if the provider initially places orders for antibiotics other than vancomycin, for some reason in this power plan, these 3 entries show up, but they're not orderable, and they won't show up on the printed paper prescriptions. They're just viewable in this view when you look at the IV prescriptions.
Okay, and there's no way of getting rid of them?
No.
Okay.
Where were we? So when the time, I guess when the time comes, the IV pharmacist can initiate the laboratory test phases and the IV prescription phase by hitting the button down here, activate. So this will activate the laboratory test phase. And if you go back to the IV prescriptions tab, if you hit activate, this will activate the orders in the prescription phase. Every time you see a blue X next to an entry, that means there's a field that needs to be, there's some information missing in the field, so you just need to fill it out. For this particular entry, we'll just need to choose a printer for the paper prescription to print to. I'm just gonna print to a PDF for, to let you guys see what the prescription looks like at the end. and just hit orders for signature. And this will be, and this is the screen that'll show you what will happen after the provider, after the pharmacist signs it. So this will, after signing, the IV prescription phase will activate, the lab test phase will activate. The pharmacy community IV notification will move from a future status to an ordered status. Ampicillin and Alteplase will print out on your prescription, and a lab rec will print out for these 3 labs in the lab phase as well. I'll hit sign. There's just a lot of duplicate labs. That's why these warnings pop up, like you can see, right? Make sure you hit refresh. From the printer, you'll have 2 prescriptions that print out. One will be the Alteplase prescription here. And the next one will be the antibiotic that was in the power plan as well. And to make a modification to the IV antibiotics after the IV prescription space has been initiated, you would just click on the old IV prescription space here, right click, then hit replicate. Well, you do all your modifications in the new IV prescription space, which is indicated with this light bulb. For instance, let's say the provider wanted to switch antibiotic to ampicillin, so you would select ampicillin, you could right click, modify, and this is just to allow us to manually type in a stop date in the special instructions field. Let's arbitrarily choose a stop date of October the 1st. Make sure to select the correct printer for the prescription to print out. And Alteplase will be shown on the prescription as well. Hit orders for signature. And make sure to fill out the stop date here as well. Then you hit sign. Refresh. And make sure to discontinue the old IV prescription phase as well. And the new IV prescription space would automatically go into a future status. So if the antibiotic needs to be initiated now, make sure to go back into the IV prescription phase and activate it. Orders for signature, and then hit sign. This will print out your new prescription. And now the IV prescription phase, the new IV prescription phase is in the initiated status. This will also be shown in the pharmacy PPM queue with an ordered status. So also from the pharmacy side, to clear these notifications from the queue, you would just click on one of the notifications and then hit view. And this takes you to Pharmacy Medication Manager. And then you can void these notifications by going under the action column and selecting void. Hitting apply. And select no closing signature required. You don't want anything printed as well. And then hit submit. This clears it from Medication Manager and clears the notifications from your PPM queue as well.
Kinson, why do we have to do that if this is a prescription?
Good question. This is kind of like an enterprise design. I believe this was based on. Oh, sorry.
Oh, I was just going to say, this is Nicole. Steve, is your question, why does that notification come to the PPM queue?
Yeah, because my understanding, at least with the oncology side of it, was a outpatient prescription, it'll just print the prescription. It wouldn't go into the PPM queue.
It's to notify the dispensary that the power plan has been placed so that the pharmacist knows that they need to activate the prescription phase in order to print the prescription.
Even though they've activated it in the phase, they have to go into PPM to void it. That notification.
So yeah, the notification goes to the PPM queue when the power plan is placed, and that's how pharmacy is notified that the power plan is placed. And then you go activate the prescription, but it doesn't automatically void that order, unfortunately. So you have to manually go in and void that notification.
Seems like a lot of steps.
Oh, hi, it's Winnie here, the informatics pharmacist Richmond. Nicole can correct me if I'm wrong, but I think when that power plan gets placed by the provider initially, that notification fires the queue. So that kind of lets the pharmacy know that someone's starting on home IV. I think at that point, Steve, we can decide whether we want to like just screenshot that notification, keep it like so we have a copy of it, and then we can just void the notification at that point. When the pharmacist goes in to activate the phase, the notification doesn't actually refire.
Yeah. Okay.
Yeah.
No, it just seems like a step that we're doing, and I can see that step being forgotten, and the queue just keeps piling up. Kinson, one other thing, when you activated the labs, will that actually print out a rec, or is it going to be assuming that those lab work will be sent to a Cerner site lab, for example, or outpatient lab in hospital?
It'll print out a lab rec. It's a generic CST Cerner lab rec, I believe. And at VGH, the patients have to take the physical paper lab rec to the lab in order to get their labs done there. And I spoke with Diana from VGH, the community IV pharmacist as well. The lab rec printed from CST Cerner can also be used at Life Labs.
Perfect.
And does anyone else have any questions? Okay, in that case, I'll stop my screen share. Thank you.
Thank you, Kinson. Are there any questions from or regarding anything that we've talked about today before we end up our session? No. Okay. Hearing none, this is the end of today's session then. Thank you everyone for your involvement in this. We have a number of follow-up items to take back, so we hope to have those ready for you in our next session. We'll be sending out the meeting minutes, slides, and recording sometime next week. So please feel free to review those. And if you do have any questions or any concerns that you'd like to bring up, please do email us as well. So stay tuned for when the follow-up session will be. It'll likely be in the next few weeks, and an invite will be coming your way shortly. If there aren't any other questions or concerns, then we'll end the session here. Thank you, everyone.
Thank you. Thanks, Tiffany. Tiffany, just a quick note. I don't have any of the buttons for the recording side, so if I could just have you hit that end recording. Sorry. Sorry, I couldn't be of any help there.